my first years in independent practice, James, a friend from medical school doing an ENT residency, called me up to ask for advice. Earlier that day, he had seen a 19-year-old woman, Daisy, who came in to be evaluated for a rhinoplasty. She was an excellent candidate, but upon hearing that insurers would only cover a nose job if there were a clinical indication for the procedure, she said that she couldn't afford it. James's attending had then re-examined Daisy and noted that her nasal septum was mildly deviated. He asked whether she had recurrent sinus infections or any difficulty breathing through her nose. When she shook her head no, he asked the same question again, after which Daisy seemed to understand the attending's intent and remembered that she had. While wrapping up the visit, the attending told James to write a letter to the insurance company stating that the patient's deviated septum was causing recurrent problems with nasal congestion, indicating that surgical reconstruction was appropriate. James hesitated, but his attending then emphatically told him to bring it to him for his signature by the end of the day. James didn't think it was right to send a letter that misrepresented the patient's condition to her insurer. He was also reluctant to approach his attending, who clearly did not want to hear his concerns. I understood his dilemma, but wasn't sure what would be the best response. James's experience is one example of how medical training shapes formation of professional identity. His attending was not only acting in a way that appeared to be unprofessional, but was also asking James to do something James felt uncomfortable with. You'll need to be prepared to respond to these challenges and pay attention to how they can affect your professional practice. But in order to do so, you'll need to understand a bit more about what happens during medical training. First, you need to know that there are two different curricula taught during medical school and residency. The first is the explicit curriculum that you'll find written in syllabi and covered in course objectives. It includes the knowledge and skills you will need to be a competent practitioner and is taught through lectures, case conferences, and bedside mentorship. The second is the hidden curriculum. You won't find this curriculum in any official document. It includes the attitudes and conventions that are passed along from experienced physicians to trainees and is taught through observation and acculturation. The hidden curriculum is like an unwritten book of rules that you learn by watching those around you. Many of these unwritten rules conflict with what is formally taught. I imagine you can think of examples from your own training where the hidden, rather than the explicit curriculum, was on display. The female medical student is told that she isn't cut out to be a surgeon. The intensivist refers to the shock liver in bed 8. The ED attending arrives hungover and exhausted after a night out with the guys. James's situation I described earlier is certainly an example. Here's a different, more subtle message that was given to me. During one of my ICU rotations in residency, I was assigned to care for a patient with recently diagnosed advanced metastatic bladder cancer. A family meeting had been scheduled to take place on my first day in the unit, and the patient's wife did not arrive at the bedside until just a few minutes before the meeting. My attending had said that she was difficult and that she was not being realistic about her husband's prognosis. During the family meeting, the patient's wife was aggressive and accused the healthcare team of giving up on her husband. Nonetheless, my attending spoke to her with compassion. I was impressed with her patience in explaining the prognosis and in answering questions. We left the meeting and walked down the hallway. As soon as we were out of sight of the patient's room, my attending turned to me with a look of utter disdain and said, "See what I mean? She just has no idea what is happening and is being completely unreasonable." The attending had acted appropriately with the patient, but I couldn't help feeling let down by her lack of real empathy for what the patient's wife was going through. I wondered if I would eventually start to feel that way about my patients. There are other parts of our work that send the message that professionalism is not really important. The integration of the electronic health record into medical practice means that we spend less time seeing the people we are caring for and more time staring at a computer screen. Evidence-based treatment guidelines can make our patient encounter seem formulaic and mechanical. The focus on patient satisfaction can make us feel like short-order cooks serving up whatever medical interventions patients order from the menu. These practices establish norms about the relationships between patients and physicians, that may not always align with explicit statements about the importance of being a compassionate professional. The second thing you need to know is that the hidden curriculum is not innocuous. During the first 2 years of medical school, medical knowledge has been shown to increase dramatically, with further growth taking place throughout the clinical years and into residency. As expected, third and fourth-year medical students demonstrate huge improvement in clinical skills, which also continue to develop during residency. However, the patient-centered attitudes that are at the core of professionalism, such as empathy and compassion, as well as moral reasoning skills, have been shown in study after study to decline over the course of medical training, coinciding with students' movement out of the classroom and into the clinic. It seems that spending time in the real medical world actually undermines trainees' inclination towards professional behaviors and attitudes. They see the example set by senior colleagues and follow the walk they walk rather than the talk they talk. The hidden curriculum is particularly influential because of the hierarchical nature of medicine. Junior colleagues are expected to follow in the footsteps of senior ones. Students defer to interns defer to senior residents, and senior residents defer to attendings. The hierarchy makes it really hard for residents like James to do the right thing when they see someone higher up the ladder act unprofessionally, or worse, ask them to do so. How should James have responded in this case? What do you think? My final point is that you need to consider how you will choose to respond to this challenging environment. Here are 2 possible ways of managing the hidden curriculum. 1. Have an approach for responding to scenarios where you believe something is really going wrong. These are the situations in which you at least feel the need to raise concerns. Asserting your opinion with a senior colleague can have consequences, but I have found a few strategies that have helped make these difficult conversations go well. To start, I make sure to talk to the correct person. It is generally best to raise concerns with the individual themselves, or, if it is clear that talking directly with the individual will not be productive, with their immediate supervisor. I also have the conversation in private, not in front of other team members. I begin by asking questions to make sure that I really understand what happened. And finally, explaining how I feel about a situation rather than making accusations about someone else's behavior can avoid making people defensive and angry. 2. Make sure you cultivate good role models. Think about a person you have come across in your medical training or practice who is the type of professional you would like to be. They don't necessarily have to be a department chair or program director, or even in your own department. Just someone who has the attributes that you would like to emulate in your practice. You may have more than one. Now here's the most important part. Ask that person explicitly to be a mentor. Explain to them that you respect the way they do their work and would appreciate it if they would be willing to serve as a sounding board if you need advice. More likely than not, they will be happy to do so, and you will have created an opportunity to develop a meaningful relationship that will be beneficial to both of you. Watch this person in challenging situations and model your behavior after theirs. And remember that you are moving up the medical hierarchy. Others may be looking to you to be their role model. When you interact with more junior colleagues, don't forget how it feels to be a medical student or intern. You have an opportunity to do what you can to make it easier for those following in your footsteps. Let's review. 1. Medical training is a challenging environment. The messages in the hidden curriculum are implicitly communicated in a wide variety of ways that you should be aware of. 2. The hidden curriculum can have negative effects on medical trainees, and it is difficult to work against because of the hierarchy inherent in medicine. 3. Don't be afraid to speak up when you feel it is appropriate. Be intentional about choosing your role models, and keep in mind that your actions and attitudes may influence others. Each of us can make a difference. A few years ago, I read a profile of Dr. Ruth Berggren in the New York Times. Dr. Berggren was scheduled to be on service at Charity Hospital in New Orleans on August 28, 2005. With Hurricane Katrina bearing down on the city, Dr. Berggren left her husband and children and went in for her assigned shift. Many of the other attendings, residents, nurses, and support staff did not show up. After a day, the building lost power, but Dr. Berggren continued to adapt patient care plans to provide the best care possible for her patients under the circumstances. Once the levees broke and it became clear that there was no immediate rescue plan in place for the patients or staff at Charity Hospital, the team members came together and made an agreement that they would not leave until every patient was safe. Dr. Berggren took comfort in knowing that her own family was not in danger, but endured 6 days without food, running water, or bathroom facilities, alongside her patients and staff before being evacuated. Dr. Berggren was portrayed as a heroine, but after reading the story, I wasn't sure that she had done the right thing by leaving her family. On the other hand, she had shown remarkable dedication to her patients. I asked myself whether I would have done the same thing. I hope that I will never find myself in the middle of a disaster of Hurricane Katrina's magnitude, but think there is something important about Dr. Berggren's story that also applies to more routine circumstances I face every day. It raises questions about what it means to work in medicine. What obligations and opportunities do I have because of my choice of career? What are the limits of my responsibilities? How can I be the type of physician I want to be? My first point, which is nicely illustrated by Dr. Berggren's story, is that medicine is a different type of career than most. Patients are not our clients, nor our customers. Our contacts with them are collaborations rather than transactions. The bedrock of the relationship between physicians and patients is trust. Patients make themselves vulnerable, giving us sensitive information and allowing us to touch their bodies in very invasive ways. We implicitly agree to maintain that trust by acting responsibly for their benefit. In return, society gives us a high level of respect, pays us well for our work, and continues to turn to us for help. This mutual, unstated agreement is what makes a therapeutic relationship between patients and their doctors possible. Imagine how healthcare would be different without this understanding and trust. Patients might withhold information, dismiss our recommendations, or avoid seeking care at all. Our work would be a lot harder and patients would not get the help they need. American and European professional organizations have collaborated to develop a physician charter on professionalism that describes the special relationship between doctors and the community where they practice. It begins, "Professionalism is the basis of medicine's contract with society. It demands placing the interests of patients above those of the physician, setting and maintaining standards of competence and integrity, and providing expert advice to society on matters of health." This message in the physician's charter leads directly to my second point. Putting my patient's interest first and practicing medicine to the best of my ability sometimes requires sacrifices. I've missed family events and special occasions with friends. My cell phone goes off at all hours of the night, and I can never take a spontaneous day off of work. There are responsibilities that come along with wearing my white coat, but I prefer to look at them as opportunities. Running a code that saves a child's life, identifying the source of a woman's abdominal pain, sharing grief with a man about his wife's death are opportunities to make a difference in someone's life. They give my work meaning and show me what matters. The great physician and humanist William Osler said, "The practice of medicine will be very much as you make it. To one, a worry, a care, a perpetual annoyance. To another, a daily job and a life of as much happiness and usefulness as can well fall to the lot of man, because it is a life of self-sacrifice and of countless opportunities to comfort and help the weak-hearted, and to raise up those that fall." I'm not always successful, but I try to appreciate the role I get to play in my patients' lives. While inspiring, Osler's perspective doesn't offer clear guidance on how to negotiate actual situations in which various responsibilities come into conflict. I remember one evening, I was finishing up an exhausting 10-hour shift in the hospital. I had given very bad news to 2 different patients and then spent the rest of the day trying to catch up after taking extra time to talk with them. It was my wedding anniversary, and I had promised my partner that I would be home in time to go to our favorite sushi place for a celebratory dinner. On my way out of the unit, I walked by the room of my patient, Miss Rose, for whom I had just received a set of discouraging test results. I had planned to discuss them with her at length the following day, but she flagged me down as I passed, asking eagerly but anxiously whether her test results had come back. Thoughts flew through my mind. Should I stop and explain the findings? Would I be able to do a good job at the end of a long day? And what about my promise to my partner? Maybe I should just tell Miss Rose that the test results weren't in yet. What is in Miss Rose's best interest? How much do my own interests count? My final point relates to how we learn to respond to such situations. Throughout medical training and in the early years of clinical practice, we go through what educators call professional identity formation. Professional identity formation is the process by which physicians integrate the norms and responsibilities associated with practicing medicine into our actions and attitudes. It refers not only to the choices doctors make and the behaviors we exhibit, but also to the character traits we cultivate during this time. Our professional identities determine how we respond to challenging situations in which difficult decisions must be made. There is no single correct professional identity. A variety of factors will affect how physicians develop habits and make judgments. Their experiences, role models, background, environment, and more. There are many acceptable ways to practice medicine, and patients will have different preferences about how they wish to be treated. Even so, successful professional identity formation must involve a commitment to acknowledge patients' vulnerability and respond by acting in their best interests, even if doing so sometimes requires some personal sacrifice. This commitment is what makes the practice of medicine possible and is at the heart of what it means to be a professional. For junior physicians, the important thing about professional identity formation is to be aware that it is happening. With this awareness, we can intentionally seek out influences that help shape our attitudes and actions in ways that make us better doctors and better people. Aristotle said that a virtuous person does the right thing, at the right time, in the right way, for the right reasons. That's a pretty high bar. We won't always be able to reach it, but knowing where it is gives us something to strive for. Situations in which we fail to live up to this ideal offer us opportunities to reflect on what brought them about and to think carefully about what to do differently in the future. Let's review. 1. The profession of medicine is different from other types of careers. It depends on an implicit social contract with society that physicians will work in the best interests of the vulnerable patients they care for. 2. Putting the interests of patients first and practicing medicine with integrity requires sacrifice, but also presents opportunities to make a meaningful difference in people's lives. 3. The process of professional identity formation begins during medical training. Intentionally seeking out influences that support a commitment to the well-being of patients can help foster a strong professional identity.